Hello everyone, welcome to our today's series. And before we start, I would like to urge all of you to please share, like, and click the notification button for my channel, and also tell a friend to tell a friend, because my main objective is to share knowledge pertaining palliative care and pain. So today I will share information pertaining myths and misconceptions that revolves around opioids. Remember yesterday I touched about pain management, whereby opioid use is one of the measures used to control pain. And the drug I'll concentrate on is morphine, because it's the drug that is widely used for our patients who have life-limiting illnesses, whether malignant or non-malignant. And to start with, I will start with the first misconception that revolves around, which is that morphine usage leads to physical dependence. And I will start by expounding what is physical dependence. Physical dependence is is a normal physiological response to a chronic opioid use, and this response also comes with withdrawal effect if the drug is suddenly stopped. So, physical dependence should not hinder the drug from being withdrawn from the patient if there has been an alternative measure that has controlled the pain effectively. Like, for instance, a patient is responding to a different drug. So the healthcare provider or the patient him or herself might feel that she is not willing to stop the drug because she's afraid that she might get those withdrawal symptoms. And the fact that clears this is morphine use will lead to physical dependence, just like other opioids. What happens is the morphine should be withdrawn gradually and not abruptly. You should not stop the drug at once. Just wean off the drug slowly by slowly, and with that, the patient will not experience the withdrawal symptoms. The next myth and misconception is about respiratory depression. Most people believe that administering morphine or taking morphine can lead to them being breathless. And the fact I want to state about this is that if the dosage is well titrated, titration means the dose is well calculated in regard to the pain the patient is experiencing, the level of the pain the patient is experiencing. Respiratory depression will not happen, because pain is a physiological antagonist of respiratory depression. So if the morphine is being administered using the right route, the right dosage, and at the right time, we are sure respiratory depression will not be the case. And some practitioners or some patients themselves might be afraid because they are perhaps suffering from conditions that are affecting their respiratory systems, like, for instance, chronic obstructive pulmonary disease, or even lung carcinomas or cancers. So this patient, what happens to them is that the morphine is given at a low dose. You don't give like other normal patients. You give the morphine at a low dose, and you should also be vibrant in reassessing the patient to see if there are any signs, respiratory signs, that are exhibiting in that patient after administration of the dose. So the other misconception is about tolerance. Most people are afraid that as their disease progresses, the drug will not effectively control their pain. And to clear that, I would like to state that morphine has no ceiling dose. There is no upper the maximum dose for it. You can give as a high dose as you can, depending on the response of the patient, and also depending on whether the patient is exhibiting any side effect of the same drug. So the next myth and misconception is about addiction. And at this juncture, I would like us to differentiate between addiction and physical dependence. As we had previously said, physical dependence is a normal physiological response to chronic opioid use, and it has withdrawal symptoms. In our case here, addiction is basically pathological physiological response to opioid use or any other drug use that leads to abnormal symptoms, like for instance craving of the drug, etc. So for this case, we need to tell the patients that if the drug is administered in regard to the level of the pain the patient is experiencing, there will be no addiction of the drug to the patient. So ultimately, I would like to talk about the last misconception, which is that morphine hastens death. No, morphine does not hasten death. Morphine can be taken for years and months as long as it is being given at the right dose. You can take it for a long time. Yes, so let us be knowledgeable about these misconceptions, and let them not confuse us in managing pain in our patient, and also in ourselves if at all we are the patients. Yeah, thank you so much. We'll meet in the next section, in the next session.